have a cold, so I have a mask on. If you don't understand me, just tell me and I'll repeat it.
Okay.
So one of your nurses asked me to do a colostomy or ileostomy.
Mm.
So the reason we do either a colostomy or ileostomy is that there is an obstruction, the intestinal fluid cannot go down, so we need to bring them out. So they could function as a opening. So when we do this portion of the ileum, that will be an ileostomy. When we do this portion of the colon, that will be a colostomy. So there's different, colostomy is colon,
Yeah.
ileostomy means ileum. And the care of the stoma is the same, but it's the complication are different. So that's what we need to know. If we bring this portion of the colon out, that will be an ascending colostomy. If we bring either this portion or this portion out, that will be a transverse colostomy. If we bring this portion out, that will be a descending colon colostomy. Most of the time we do, the commonest reason we bring a colostomy in America is this portion of the colon, just proximal to the sigmoid colon. The reason being, the commonest reason is the perforated sigmoid diverticulitis. We do the colon resection, we can't put it back together because it's a peritonitis inflammation. So most of the time you're going to be dealing with this or this.
Mm-hmm.
So these are old-fashioned, we don't do them anymore. And ileostomy, so this is your abdominal wall. This is your belly button. Ileostomy will be most likely here, and colostomy will be more likely here. And usually it is your iliac spine and your umbilicus. So in that line. So in the middle we put it, always through the rectus abdominal muscle. If it is away from, if you see the colostomy little outer than abdominal muscle, then there's more complications. Because the rectus abdominal muscle is a muscle right along the midline. If you go laterally, those are the external oblique, internal oblique. You make the area much weaker, you're going to have more paracolostomy hernia. So ileostomy could be endileostomy, just like the ileum is coming down. And many times we bring this portion out as a loop ileostomy. You will see the two lumens, one proximal, one distal. Because those we do, if we do a very low rectal anastomosis, to protect the anastomosis, we do ileostomy. So if you see the two lumens, you're going to ask why there are two lumens. So that's why there are two lumens. Yeah. So the post-op care is really the most, that's where you guys come in. You are our eyes looking at the things. So in the first 24 hours, what is the most common complication in the first 24 hours? Speak up.
Bleeding.
One of the complications.
The necrotic of the tissue of the
So you are looking at the color of the stoma. And if you look the color, first it might look pale, and then it will become blackish, then we need to know. Okay, usually within 24, 48 hours, that's where we always come and look at the stoma in the first 24 hours. Because if it is ischemia, if it is very little mucosal ischemia, then it's going to slough, and then you're going later on, you're going to see the ostomy is not on the skin, it is way down under the skin. So then we have to go revise it. If the ischemia goes up to the peritoneum inside, that has to be done in the operating room. You can save that. Second was the bleeding. The bleeding usually is a very small amount of bleeding, unless some patient has a bleeding issue, so then you may have a lot of bleeding. Yeah. So later on, we see the stricture, it becomes very narrow, and that's usually the function of the what kind of appliances we use. If we put too tight around the stoma, and that makes it tighter, slowly it becomes stricture. So when you guys put the bag over the stoma, how much you cut?
We use
The size
ring
of-
the measures of the, yeah.
Okay, so how much more you extra?
It's very little.
Yeah. It is usually between 1/16th of an inch or 1/8 of an inch.
Oh.
Has to be bigger than that. If the stoma is say 3 centimeters, so the wafer you're going to cut will be slightly bigger than that.
Yeah.
Because if it is overlapping the stoma, it's going to leak, it's going to bleed, and then it's become gradually start to get narrow. So that's how we need to. You will say, well, if it is a little bigger, then it's going to leak on the skin, it's going to be skin excoriation. It might be, but if it is very tiny, it's not. Main thing is to seal. You guys should be better than me. I don't put colostomy bags, or I don't. My function is just to make them. It's the sealer have to be properly applied, and it has to be air and water tight. Because if air leaks, the stools are going to leak, and you're going to have excoriation, inflammation, and that's become very painful. So, what are the later complications?
Prolapse.
Those are the initial complications. What are the later complications?
Constipation.
You can get a constipation on the ileostomy side. What is the last complication?
Prolapse, a little complication. Prolapse, when it comes out.
That's a prolapse. That's a very late complication. Yeah. Okay. So the bleeding we did that, skin excoriation we did that. It's a prevention. On the ileostomy side, you may also have an issue with your hydration, your nutrition, your electrolyte balance. On average, ileostomy output is between 200 to 700. So if it is 2 liters, a liter and a half coming out every day, now we have to replace their fluids. And then more fluid we give through the feeding, the more fluid is going to come out. So then we have to supplement with the intravenous fluids in those patients initially. Ultimately, it will figure out how to adjust itself. So on the ileostomy side, it should function within 24 hours. If it is not functioning within 24 hours, you need to see if abdomen is distended, or they're getting obstructed, or there's a profound ileus. There are many, many reasons that it doesn't. Ileostomy usually function within 24 hours. And what we expect from ileostomy, what kind of fluid we are going to expect? Liquid and what color?
Yellow, greenish.
The greenish
Okay.
yellow. Okay. So we know the bile is coming out. So we are satisfied. What we expect from the colon side?
More form stool.
What we expect first?
Oh, just little liquid maybe.
What we expect first?
Gas.
Yeah.
I didn't go back.
So that's why we come and look at the bag. If it is bloated up like a balloon, it start to function. The stool may come later, but the first thing is going to come gas. Then you're going to get a brownish fluid. So mostly on the left side, it's just like a natural bowel movement. So you're going to have a kind of pasty stools, then you're going to have a constipated stool or a regular stools. So you're going to say, well, patient has a colostomy while they are constipated. But they are constipated because naturally if people are constipated, colon doesn't know whether it's coming through the anal opening or through the abdominal wall. So those people have to be real carefully monitored. Because if they get constipated, then you have to do either stool softener, enemas, and all that. On the left side is much easier to manage because many people have a stoma and they do not put a bag on it. They irrigate themselves on a daily basis so the colon get evacuated, and then all day they can walk around without the stoma bag on. But usually it doesn't function. If you're very healthy, young, and you are working and you don't want the bag to be hanging out of you, you can do that way. Other issue we deal with on the colon side is the smell of the stools. People don't like it. But there are a lot of things available. There are blue tablets they can put inside. Actually, the bags are now coated with chemicals which can eliminate your odor and all that.
So you don't see that stuff.
But there's that, you see, we used to have an ostomy nurse.
Not anymore.
Yeah.
But now the wound
But we
nurse,
still-
she's
Oh, the wound
ostomy,
nurse,
yeah, the new
yeah.
one is,
But we
She's
still.
the ostomy nurse also?
yes.
Yeah.
We don't have the supply
still-
sometimes.
No, she's working on it, so she will,
Yeah.
she's talking to the prep, so she will get a supply.
Yeah.
I mean, I can remember at St. Clair's, they used to have this little black tablets that we used to put in it, but we don't have.
Those charcoal tablets.
Yes. Yeah.
Oh, so she was very good. Okay. She was actually a wound care and an ostomy nurse. So she knew all kind of tricks and how to prevent complication, what to do with the bag. She was good at teaching to the nurses, so we didn't have any issues. And then she's gone for almost 5 years, 6 years.
Teresa, right?
Yeah.
Teresa.
Yeah, she's gone for 6 years.
So this one is also ostomy nurse, so
Yeah.
that would be.
So you mentioned prolapse, and that's usually happen more on the ileum side than on the colon side. So that it depends how much prolapse is. Usually it's a very tiny prolapse and it doesn't really help in the function of the ostomy. On the left side, if the prolapse is quite big, then you have to go back. But you don't have to go back inside the abdomen. You can just undo the skin anastomosis and gradually dissect it out till it reaches there's no tension. Then you can revise it. Yeah. That's usually a function of constipation, straining, whatever reason. Next one is the paracolostomy hernias. Those are more common on the ileostomy side than on the colon side. So you will say, why we are getting paracolostomy hernias? See, when we cut the fascia from the inside, or a peritoneum, we are making about 2 finger breadth opening, but it's open. There's just a inflammation and the healing process, but there's no muscle at that level. So every time we cough, every time we sneeze, we are making it bigger, People who usually have respiratory issues, smokers, obese people, poor healing, renal failure patient, any of the process where you are ill otherwise, you're going to have a more complication with the colostomy. So then those people need to go back and have it revised. So there are a number of ways to do, but that's not a discussion. So the message is the ileostomy is almost always on the right side, colostomy is almost always on the left side. Extremely rare, at least it's not done anymore. It was a routine for the surgeon in the past. Put through the belly button. Ileostomy. They thought it was center, would be easier to manage. That's the most difficult place to manage your ileostomy. Yeah. And also with a colostomy nurse, when she was here, if I was going to do a colon resection and I was anticipating to where the stoma should be ideally, we used to ask her consultation. So she will have people stand up,
And that's your.
lie down, see where.
Like, do they still, like years ago, they were like with Revenant, like he would ask like a guy, where's your pants? Like, and the belt and all that, and then.
But
you
that's what
guys
I'm
do
saying,
that?
in a planned colostomy,
You could do
you
that.
could do all that. But most of the time, we are doing a colostomy in an emergency. So we are eyeballing where to do. So that's probably not the proper way to do. So, like, if I have a patient and I was anticipating this diverticular, so we can ask the ostomy nurse, could you come and mark the area? But still, it's a guesswork. So yeah, it should be below your belt line, but you remember, years ago, belt line used to be higher. So that statement doesn't do well. It should be below your belt line because it's not going to happen.
Well, the guys wear them way down.
Yeah, so it means, yeah. So usually umbilicus, anterior iliac spine in that line, and right in the middle, that's where the most of the ostomy is going to be, yeah. What kind of powders you have or cream you have for the skin excoriation?
We only
We only have one type of a powder, and then we used to have the paste, which is now is very hard, but we have the circles that we can apply them, you know, after we mold it and fix it around.
Yeah.
And then we only have one type of colostomy bags. And sometimes it would be nice to have two separate, because two pieces, because those are the ones that they are not, we cannot get them to stay, you know.
Yeah.
Because I know that I'm talking long time, but the two systems, sometimes they used to have a belt that they clip on it just to keep it in,
Yeah.
and then we put the other one. That would, it seems to function.
What is the advantage of that?
The
The
Yeah,
two
two pieces,
pieces,
yeah.
It's easier
It's
for
easier.
them to, it's easier to apply, and it's easier for a patient to just take
Other
the bag.
advantages can stay up to 3 days.
right, right.
So you don't have to change every day. You can
Right,
change every
right.
third day.
Right.
You can have a clip-on bag, either you can throw the bag after each use, or you can empty it. Remember there was a roll-up
Right,
bag?
yeah,
and-
yeah.
So I usually in the office, if I see my people have a little issue with their excoriation, Desitin
Oh,
is the
Okay.
best healer. So I asked them to put a very tiny Desitin before they put a bag over,
oh,
and then usually
Helps
the
it stick.
excoriation, yeah. But just a very tiny,
Oh, around,
Yeah.
like, close to the stoma area?
around where the
where is the
excoriation is,
excoriation?
and then you put a bag over.
Cause we used to use the powder,
Yeah.
then skin prep,
Yeah.
powder.
You do all that, then you put a little Desitin and you do, yeah. It works.
Okay,
Yeah.
we'll give it a try.
Yeah, it works. Desitin has a zinc inside.
Yeah.
Yeah, so.
Yes, we use that too for the baby rash, right?
Yeah,
Yeah,
yeah.
baby rash, you know,
Yes.
baby
Yes.
rash or triple B, you know, all
Yeah.
kind of
Yeah.
treatments are available, yeah. Anything else you guys do what I don't know?
Well, we have those cases that are very excoriated. Remember, Marion, the one we have to put the kind of like, what was it? It was not tegaderm. It was the very clear duoderm, very thin, because it
Oh,
was very, and we couldn't get it to stick
We've
until,
done that too, yeah, the
Yeah, the
duoderm, and then put
duoderm.
the,
yeah,
Yeah.
just to get the stick. You know, so we have a lot of different,
Skin gets
try anything
and
so
then
they can get
holding
stick.
it and
Yeah.
the heat
Yeah,
helps. Yeah,
So we don't have in the office any referral system. I think there used to be one in Memorial Hospital. They're closed, so there's ostomy nurse outside in Amsterdam, St. Mary's
Okay.
Hospital.
Right,
So
right.
that's where we are sending people.
we had
So it's just
one.
unfortunate that we don't.
Right, and then we also used in one patient that we consulted the St. Mary's ostomy nurse, and they gave her a special you know, things that she can come and take a look at it and tell us what to do, you know, so. And then we used to paint it, it was purple, we used to put around for the excoriation, and then put it in, and it really worked.
So on the floor, what I suggest, that each one of us probably deal with a, in a colostomy care, a different complication.
Yeah.
So one of you become expert at one complication, so you took care of the patient. Yeah, that's how we learn.
Right, that's
From
true,
one
that's
to
true.
another.
Yeah, yeah.
So if every one of you knows one part to take care of, one complication to take care, you share the knowledge with each other, you ask each other, and pretty soon there are not many complications that we should be able to
Right,
take
right.
care of. Yeah.
Yeah, Mary Ann and I, we
We
always
always-
got together to the problems.
So the reason I didn't go to detail why we do these, but there are so many diseases that we do decide, make a decision. So the only function was the ileostomy and a colostomy. So when we do the loop ileostomy, the reason we do that, because the distal end has to go someplace, because it may not secrete into the colon. So that has to call mucus fistula. Only thing different, another thing we add, we call colostomy and a mucus fistula. What's the difference between colostomy and a mucus fistula? You will see two bags. So you're going to ask me which one it is going to function.
Right.
So which one is going to function? Let's say, yeah, what is going to come out that, if this is the colon, right? This is going to come out here, this is going to come out here. So this will be a colostomy, this will be a mucus fistula. So what is going to come out of the mucus fistula?
Lower intestines. Mucus.
Mucus?
That's why it's called mucus fistula. So there's no thinking involved.
Okay.
So you will say why we do this, okay. Let's assume that you have a obstructive rectal cancer,
Oh,
okay, and you can't resect it.
mhm.
And then you are going to do a diverting colostomy. But if you just bring out a loop colostomy, the stool will still go down and they will still have issues, the pain, and the stool get dried up and obstructive. So you want to have a mucus fistula, so egress, the mucus at least comes out. So that's the reason to colostomy and a mucus fistula on the same patient, yeah. So that's radiation, incontinence, reason obstructive cancer, all those people will need a double colostomy, we call it. But one is a function, one is a mucus fistula. Rarely done these days,
I've
but that
never
used to
seen
be
it.
very common, yeah.
Dr. Syed, when you do that, do you put them both under the same appliance or do you do a different bag for
A
each
different
one?
place.
That's what I-
Yeah,
Oh.
different place, yeah. Because
So you
this
can
will
monitor.
retract.
I mean, I've seen them where they blend like side by
So
side.
would
Well,
they-
that will be your
I've never
ileostomy.
seen it. Yeah.
The loop ileostomy.
That will be your loop ileostomy, or if it is a transverse colon, like say I did colon resection and I was concerned for the anastomosis, either I will do ileostomy or I will do a loop colostomy. So reason being, 3 months later, I can just close up the colostomy and then you will see the two lumens.
So will it be enough space for the supplies because it's pretty big?
But the loop it should be the same.
Okay.
Yeah, it's just that you are bringing a loop so it communicates, that's why we call it loop.
So then we're using one supply for.
Yeah, just one supply, it's a one skin opening.
Okay.
Yeah, we're calling a loop because the loop is coming out instead of end.
Mhm.
So anytime, actually the definition will tell you. Ileostomy, loop ileostomy, so then you automatically know they are going to be two lumens. Loop colostomy and a colostomy. So it tells you, it's a colostomy, colon, it's a loop, it's a double lumen, mucus fistula. She was not on this floor. Recently, Dr. Satish had a patient where she had a gastrocolic anastomosis which leaked. Years ago, she has a bypass. He went and put it back together, leaked again. So he brought the ileum out. So there was nothing going to come out of it because she's not connected to the stomach and to the intestine anymore. So that was mucus fistula, but actually it's a part of the ileum came out.
Yeah.
She was on A5, yeah. Any questions?
So then when it's, I don't have a question. So for us, like when it's time for discharging a patient, so now when we see, for example, for the colostomy, we already seeing there's gas and stuff, we have to wait until we see stool? Or
On the left side, I do wait, but if it's a stool, the air is coming out, I know it start to function.
Yeah,
Then I'll start with the clear liquids.
okay.
See what happened in the next 24 hours. If you see the stool, then they could eat
Mhm.
normal food. It's just like a normal person.
Right.
You're having bowel function, then you feed them. On the ileostomy side is much quicker, but we have to be careful, even though it is functioning, their normal function, they may not be ready yet. So we start them on clear liquids, then full liquids, then regular diet. You may have to manage on the ileostomy side. If they're eating too much fatty food, then they're going to have a lot more stools. Especially with the ileostomy, if they are on the tube feeding, then you may have a more issues with the consistency and electrolyte balance than with the normal food. Very rarely you will see that all of a sudden the stool volume goes to like 2-3 liters on a tube feeding. They were doing fine, and then you will say, what happened? So we see a complication with the tube feedings, and you do the X-ray and you will see a pneumatosis. You will say, but the radiologist is going to read possible necrosis of the bowel. But your stoma looks nice and pink. It's not a necrosis, it's just a tube feeding issue. We stop the tube feeding for 2-3 days and it resolves.
So that would be helpful if we increase the fiber with that little bit of meat. Would that decrease the liquid loss?
Either you will do or you will give cholestyramine. Cholestyramine is a powder which
Right.
binds the bile salts. It comes in a two form, the capsule and the powder.
Mhm.
Usually I start with a 1 packet a day, and if it is not helping out, then 2 packets a day. Usually 2 packets a day will take care of that.
How about opium?
Say it again.
Opium.
Opium, well,
Yeah, we
Remember?
used to have a patient that we used to give them
Yeah,
this
opium
drugs,
a
yeah.
tincture of opioid,
With
so
the
to
yeah,
decrease
she
because
was
she
like
had,
nothing.
I mean, she had the
Countermine.
but
Yeah.
then
What's her name?
Going
cholestyramine
way
is not
back.
available.
Yeah,
in
way,
those
way
days.
back.
Kill him.
Yeah.
We used to.
I personally do not like pain medicines. So any narcotics, any kind of thing can interfere with your functions and makes it difficult. Yeah.
She had a malnutrition because of the ileostomy, and they have tried everything, and the the opioid.
It just
tincture
slows down
opioid,
your
yeah.
peristalsis.
Yes.
It gives you time to
Yeah.
absorb.
Yeah.
Yeah.
Yeah. Yeah.
It comes in drops, right?
Yes.
Yeah, opium
Yeah.
drop.
Yeah.
I
Yeah.
haven't used it, never used it.
Yeah,
Oh,
that's
we
how-
had it. Oh my God!
We
Yeah.
felt bad for her. I mean, they
And she eating.
But that's for the trouble ones, yeah.
Ooh,
She was eating
because-
too much.
Because she was hungry all
Yeah,
the time.
yeah.
You know, I mean, we're talking about in the 90s.
she was a freak. I loved her.
So you ate it
80s.
yourself?
I know.
80s and
80s, 90s, yes.
90s.
And beyond.
Yeah.
Any more questions? Okay, have a good day.
All
Any
right.
topic
Thank
you
you.
want me to do next time?
G-tubes.
Mm.
I mean, NG tube. I mean,
We did
gastric
that.
tube. Gastric tube.
Yeah,
You
and-
want a
We did
GJ?
GJs.
Okay,
yeah,
Understanding
yeah.
what we're looking at.
Okay,
Yeah.
let's,
These
let's
would
do
be really
the GJ. I
helpful.
think
That'd be
Dr.
nice.
Didn't Dr. Cole did the G tubes?
No, the NG tubes.
She just went G tube.
Yeah, but it's the G
And the
tubes
JP.
and the
GJ. Okay, we'll do the gastrostomy and the jejunostomy and a GJ. There are
Yeah,
3 kinds.
yes.
Okay.
Yes.
Yep.
Okay.
Thank you.
Thank you.
Take the chair.